Good evening, everyone. So I'm Dr. Arun. So I'm currently working in UK as a senior clinical fellow. So I've done my European diploma in intensive care with Farz Academy last year, and I passed successfully. And my area of interest is point of care ultrasound, and I'm a Physic Heart and Lung mentor, which is a training program accreditation in uh, the echocardiography and lung ultrasound. So congratulations everyone for joining this session and clearing EDIC part 1, preparing for part 2. You are in really safe hands with Farz Academy. It's one of the most effective courses available online currently for part 2. The objectives for this session, I'll try to orient you towards like EDIC part 2 exam, more towards the CCS this session. So this session is going to be like a simulation of the actual exam. So I prepare the slides just like the actual exam with some discussion like related to that. And this is the best place for you to practice answering and will really help you pass the exam. So be involved, try and answer. And yeah, I will try and modify your answers if there is any requirement which is need to be adapted to the exam standards. So let's keep it interactive, and the more you talk, more you will get benefited. So I encourage you to strongly uh, get yourself involved and take maximum out of this. Please keep your videos on if possible, so we can interact each other, and I can see some of your names, so that's fine. And yeah, if possible, we can encourage everyone to participate and answer. That will make it more interactive and engaging for everyone, and it will be helpful for you as well for the exam. And feel free to interrupt and clear your doubts as and when needed. There is some echo going on, so I'll try to address that first. Fine. So let's start with the exam case. A 45-year-old man with a history of heavy alcohol use presents to the ED with a 24-hour history of severe constant epigastric pain radiating to his back associated with nausea and vomiting. So on examination, he is tachycardic, heart rate 110, hypotensive, and has epigastric tenderness. His abdomen is distended but soft. Initial bloods you have done, amylase is 1500, lipase is 2200, counts elevated, hematocrit is 48, creatinine is 1.2, lactate is 3.5. What's the most likely diagnosis, and what are your differentials? Why don't we start? I hope everyone can answer. You are not busy, or if there is any problem, please send me a message so we can see in the chat. I won't asking you questions. Anyone open to answer?
Okay, let me try. John. Yeah. Okay, the most likely diagnosis in this case is an acute pancreatitis.
Excellent.
Yeah, the differentials will include all the causes of pain in the epigastric and chest area, like acute MI, acute peptic ulcer disease, aortic dissection.
Yeah, very good.
Yeah. Acute pericarditis. It's also a possibility.
Yeah, these are the common things, right? But you got it really correct. And here we have more clear, like the lipase is elevated, so we are pretty sure it's pancreatitis. So there's no problem with that. So how are you going to manage it?
Okay, my first step in the management of this case is I apply ABC of resuscitation. In this case, I'm sure from the history, the airway is patent, and possibly this patient is breathing well. So the most important need now, because of there's hypotension, blood pressure is about 90, borderline hypotension. So fluid resuscitation will be uppermost in the management, and at this point in time, resuscitate with rain gas lactate, and then analgesia. We will also give him analgesia, preferably opioids like maybe fentanyl or fentanyl to relieve pain. That would be my initial first step: fluid resuscitation and analgesia.
Yeah, fair enough. So anyone else have anything to add? I just wanted to discuss in these topics how we are going to manage this patient. Let's discuss each one in detail. Like you said, I like to answer of ABC, but more refined answer compared for EDIC exam, I would say like A to E assessment, a rapid A to E assessment, and address each problem then and there, then proceed to the next stage. Yeah. So that's how I would put it. That looks slightly better rather than simply saying ABC. And you touched upon analgesia. Anyone, I mean, whoever is free and confident can open up and answer. Even if you say anything wrong, that's absolutely fine. We are just here to share knowledge and learn from each other. So feel free to unmute yourself and chip in. So with regards to analgesia, let's discuss analgesia. So what are the problems with opioids? You mentioned fentanyl. So what is the problem you face with fentanyl or opioids in general in pain management in related to these patients?
Okay, one of the most important concerns would be that it may cause, because they cause spasm of the sphincter of OD, and it might it might worsen. Of course, it may cause a bloating of the intestines, and we have bloating. That's a gastrointestinal motility may be impaired as a result of the opioids.
Exactly, ileus.
Yeah.
Already, because of pancreatitis, they are going to have some ileus, and this is going to worsen the problem. So it's difficult to choose an analgesia in the outpatient setting, like as an inpatient, even outside critical care area, when you are like when where you cannot use the other options like ketamine and dexmet safely. But these are the other options nowadays coming up in critical care, alternative to opioids. That's the thing about analgesia. And anyone else want to comment on nutrition? How are you going to manage the nutrition?
Start early enteral nutrition.
Mm-hmm.
We like to give nutrition through nasogastric tube. First, encourage the patient to take orally. If not possible, then I will put a Riles tube and encourage nasogastric nutrition. And if still patient is not able to accept, then I will put a nasojejunal tube. Total parenteral nutrition is reserved for patients having GI motility issues or peristalsis. And so we basically aim for early enteral nutrition in these patients.
Yeah, you're absolutely correct. I think the dogma of the previous years, previous decades was like giving pancreatic rest and not feed the patient, but we are moving away from there. And if you read this American Gastroenterology update, which came out in like 5 years ago, they even talk about doing like gastrostomies in patients who are not able to swallow and not tolerating NG or NJ, even before considering TPN, which I found really interesting. Yeah, but you are absolutely correct in whatever you said. Then moving on, fluid management. Anyone else want to chip in?
Sir, can I answer?
Yeah, absolutely.
Regarding fluid management, initially, if the patient is hypovolemic or if there is evidence of shock, we can give a fluid bolus of 10 ml per kg. And after that, we will give a maintenance of 1.5 ml per kg per hour for the initial 24 to 48 hours. Too aggressive resuscitation is not advocated now.
And why is that?
Because
Waterfall trial.
Yes, waterfall trial. It has shown to increase fluid overload complications like pulmonary edema, ARDS.
Yeah. And more worrisome is intra-abdominal hypertension as well.
Yeah, intra-abdominal hypertension here.
Patient. So what fluid is preferred? Is there any preference of what kind of fluid you want to give?
Crystalloids are preferred. Ringer lactate can be given, or else normal saline. And if the BP is not maintaining, we can start on vasopressors.
So yeah, you're absolutely correct. So ringer lactate, some evidence there is advantage over normal saline. That is the preferred choice as a first fluid of choice. Then, as you said, not to go overboard with the fluid management, not to be too aggressive. But it's often they end up getting a lot of fluids and it's difficult to manage without vasopressors in these patients. So yearly vasopressor therapy. So that means definitely they are coming to the critical care at that point for some vasopressor therapy. And it's kind of similar to burns management, but burns at least you are having excessive fluid loss in one side and you are replacing it the other way. But pancreatitis, you are not losing anywhere. It's just staying within your system, but it's a capillary leak, basically, right? Yeah. Anyone else have any questions on so far with the management? Fine.
Okay, you confirm that the dose is 10 mils per kg as bolus, followed by 1.5 mils per kg per hour or so.
I don't think there is any specific recommendations regarding the dosage, unlike in sepsis where we have a guideline saying like up to 30 mils per kilo in like initial 3-4 hours. There is no such guidelines here. All the guidelines suggest a consensus statement. Basically, there is no hard and fast rule here. So basically, we are guided by like anecdotal evidence. So everyone gives a caution not to go too aggressive with the fluids, but there is no certain cutoff like this should be. Yeah. So you can just answer like I will be cautious with the fluid management, but the fluid requirement is more than just like a maintenance fluid. And you need to use your hemodynamic parameters and hematocrit, other monitors to guide your fluid therapy. It's not an easy answer, even if you are like titrating based on the end therapy, like cold and directed cold therapy. It's difficult to manage this patient and they present in different ways. So there is no single fixed answer for this. Yeah. So anyway, if you are struggling with fluid management, I think the patient is a candidate already for critical care admission. So my next question is, how do you decide on such patients on whether they need high dependency unit or ICU admissions? How do you decide on that?
Severity scoring with the help of Ranson score and BICAP score.
All right. Yeah, we will discuss scores in the next slide. I have a big slide about that. Yeah, fair enough. Yeah, we can discuss, come back to this topic later. And alcohol withdrawal. So how do you manage this? This patient has been heavily drinking, and often these patients come in with pancreatitis as well. So how do you manage alcohol withdrawal? Okay. Go on. Have you managed alcohol withdrawal previously? What's your experience with pancreatitis patient? Anyone willing to share? John, what's your experience? Alcohol withdrawal.
I've not really been involved in. I'm in Saudi Arabia, so we don't really have cases of alcohol.
Oh.
You know, but I think maybe I just give vitamin B1 infusion. You know,
We give lorazepam, high dose lorazepam, and thiamine. Thiamine should be given before glucose to prevent Wernicke's encephalopathy, and multivitamins.
Yeah. So, I agree. So chlordiazepoxide is the first line of management, but it's I think there is a current problem with availability of chlordiazepoxide. I don't know what exactly is causing this, but across UK there is no chlordiazepoxide is not available. So we use benzodiazepine, other benzodiazepines which are available like diazepam. If the patient cannot tolerate oral diazepam, we go for IV lorazepam. Or if there is any hepatic derangement, liver failure, then we prefer lorazepam. And basically, how do you decide on the dosing of lorazepam or any benzodiazepine? Do you know any scoring which is used to monitor alcohol withdrawal?
Kivasco.
Yeah, nice. So we do that, and it's usually done by the bedside nurse. So it has like multiple factors like hallucinations, tremors, sweating, and anxiety. So there is a score, like based on the scores, we can classify them like mild, moderate, severe withdrawal, and based on that, we can every 2 hours we can give the benzodiazepine basically. Isolated alcohol withdrawal management is straightforward, but combined with the pancreatitis picture, it clearly muddles the, like we will be struggling with fluid management, delirium management, and withdrawal as well as pain management. So it gets more trickier when the patient is acutely withdrawing in the presence of pancreatitis. How would you like to investigate further? So we got some initial bloods. What else do you want to test in this patient? How would you like to proceed? Anyone else want to answer this? Dr. Anika, Ravi, Sham, if you can, please pitch in. Whatever you feel. Just need
okay,
a
let me say something. I think I would like to do a chest X-ray to rule out maybe pleural effusion, and that might occur in pancreatitis.
Yeah. And also it is helpful in one of the scores, BISAP score. So I think we need to know if there is pleural effusion or not, which helps in scoring. So yeah, absolutely, I would do a chest X-ray. Yeah. Go on. So if there is a question like this, there can be like up to 5 points.
And then I'll also like to do. Yes, then I also like to do a contrast CT of the abdomen to help to visualize the pancreas and be able to grade it accordingly. Sometimes you could have a pancreatic necrosis, fat stranding, and pseudocysts. To determine the severity of the pancreatic injury, and the management will also depend on the findings on this contrast abdominal CT.
Okay, fair enough. We will come back to that contrast CT. Anything else? So, like I was saying, so like an open-ended question like this may carry like up to 5 points, 5 marks, I mean. So you may think it's a simple answer and leave it off, but it may actually carry a point. Even like a simple investigation like ECG here may carry a point. You never know. So try and answer as relevant possible answers as possible. Keep coming up with the answers. It is a time.
Okay, so I would like to do my chemistry. Okay, and I'd like to carry out my chemistry panel, to rule out hepatic involvement. Sometimes whatever is responsible for this pancreatitis may also be blocking the common bile duct, and so there might also be cholangitis in association and hepatitis. And of course, we'll also carry out do a renal function test to rule out acute renal injury that may have been associated with this acute pancreatitis. And like you said, it's ECG will be very important in this patient to rule out myocardial injury. Sometimes these conditions may actually coexist, so it's important to rule it out as well.
Excellent answer, John. Anyone else want to add anything to what John said? How do you like to investigate this patient?
In case of the blood parameter, I would like to add the serum calcium level, serum TZ level, triglyceride level, blood glucose level, liver function test, renal function test, and others like the serum renal imaging, chest X-ray and abdominal X-ray in the erect position, ultrasonogram of the whole abdomen, especially in the hepatobiliary system, and if any need, ERCP can be planned.
Excellent. So you covered almost everything. So why you need to know about the calcium and triglycerides?
So in case of acute pancreatitis, there is a hypercalcemia itself causes acute pancreatitis, and acute pancreatitis causes hypocalcemia as a complication, and hypertriglyceridemia also causes acute pancreatitis.
Excellent. So that's the entire the treatment for hypertriglyceridemic pancreatitis is slightly different from the regular pancreatitis. So absolutely, you are bang on. With regards to CT, John was saying you do a contrast CT. So what is the best timing to do a CT? We know the diagnosis is pancreatitis here. Doing in the first day of admission, does it make any difference in the management, or would you like to wait and do it on later point?
So CT contrast, CT with the contrast is usually when indicated there is an we doubt about the diagnosis of the acute pancreatitis, or there is a thinking about a local complication like necrosis or cirrhosis. In this case, we usually it is recommended after maybe 5 to 7 days after when necrosis usually develop.
Yeah. Yes, John. So I wouldn't go ahead and do a CT on admission, but I would be thinking about it if the patient is deteriorating and we don't have a clear diagnosis as discussed, and preferably after 3 days to have a better, let the disease progress, then we can use it to prognosticate and assess the complications like we discussed. So initial CT on admission, it does help, but doesn't give you the accurate picture of the severity of pancreatitis. Initial picture may not be severe, the scoring will be very low, but the same patient will go on to become a severe pancreatitis in a few days if you repeat the CT scan on it. So that's why I would avoid CT initially. So even if we do a CT, do we still need ultrasound?
Yes, ultrasound is the best.
And
we do. Sorry.
Yeah, you're correct. I just asked why do we need the ultrasound even if we do a CT in the first place?
Ultrasound help us to diagnose the stone, calculus cholecystitis, and also helps in diagnosing the calculus cholecystitis. And
yeah, correct. Yeah, basically it's for the stones. Not all the stones are radio opaque. Some of them are not. So basically to rule that out, we need ultrasound that is one of the common reasons for pancreatitis. We need to look for it, even if there are like other risk factors for like alcoholic history in the background. Fine. Have we missed out anything from here? I think we have discussed. So far, any doubts? So this is just a classification of pancreatitis, which I think is really good. So early pancreatitis, late pancreatitis, the classification just based on timing. It helps us manage these patients differently. Early pancreatitis is when they are like fluid dependent, inflamed, and require a lot of resuscitation. Then based on severity, which is the modified Ranson's, mild, moderate, and severe. And we need to wait for at least 48 hours for the disease to evolve before we classify them. And based on morphology, it's either interstitial pancreatitis, which is presence of edematous pancreatitis on CT, or necrotizing. And based on that, in like 4 weeks time, they may develop a pseudocyst or a walled off necrosis based on how they progress. So next question, like slightly we touched upon this, scoring. Priyanka, you said you will use the scores. Do you want to talk more about what exactly you will use and how will you decide on ICU admission? Or anyone else if interested, yeah.
So initially we can use the Ranson score and the BISAP score. Ranson's at admission and 42 hours after admission.
Yeah.
Also with the other scoring systems. And if you are taking a CT, we can use the Balthasar CT scoring system.
Yeah.
And accordingly, we can stratify. But the most you commonly used is the BISAP one that we can use at the bedside.
Do you know what is the problem with Ranson score?
There are multiple parameters. Multiple lab investigations are good. I don't know, sir.
But you are correct in saying like multiple parameters are required. Yeah, let's go through the scoring. Anyone else have a different score? Have you used any other scores clinically in your experience?
There is a Glasgow Emery score, Apache.
Yeah.
So fast score as well. We can.
So
Atlanta classification also.
Yeah. So
revised Atlanta.
Revised Atlanta, yeah, yes. So this is my kind of review of the scores available. Yeah. So let's go one by one. So the armless acute pancreatitis score, I really like this score because it helps us clearly differentiate which is mild pancreatitis, which is a severe pancreatitis. Just with 3 parameters based on hematocrit, creatinine, and if the patient is having peritonitis features. There is clear cutoff which we don't need to memorize, but we can always remember variables. So just with these parameters, it helps you say if the score is 0, none of the parameters are positive, then definitely the patient is having mild pancreatitis and doesn't require critical care admission. So it's kind of easy tool to just say if the patient is going to deteriorate or not. And yeah, it has very good specificity and positive predictive value based on the initial study. So I quite like this score. Coming to Ranson score, it's one of the oldest scores used based on studies. It was like published 30, 40 years ago. Still, the score on admission, if it's more than 3, it is likely to be severe pancreatitis, and it's quite useful clinically to decide whether the patient needs admission or not to the critical care. And the second part of the Ranson score is what problematic. It overestimates mortality. Like even if it's scoring like 5, 6, it gives like 100% mortality, which is not accurate. Now with the critical care, so much advancements have come in the recent decades. So it's not relevant to the current score, the mortality. So that's why it has taken a back seat and we use more of BISAP score. So BISAP score, it's easy to remember, just blood urea nitrogen. It's basically it's a mnemonic and patient is having impaired consciousness. So coming there, this patient could be confused because of alcohol withdrawal as well. We don't know. So that's where it it causes confusion in the clinical picture with the scoring of pancreatitis. Pancreatitis might be mild, but the patient, because of delirium, he might score a bit higher. And again, SIRS, he might be tachycardic, tachypnea just because of withdrawal. We can't really say if it's because of pancreatitis or delirium. And age, pleural effusion, which we discussed on the X-ray. So it's a simple score, just 5 parameters, and it's as good as other scores like CT severity index, Apache score, and doesn't require that many variables to calculate. It's easy to calculate, and we don't even need like lab parameters. So that's the advantage of PSAP score. So coming to CT severity index, the problem, as I discussed, if we do it too soon, just on the first day of pancreatitis or the second day, it will just show like, it won't show you the complications. It won't show you how severe it is. It might just, the score may be very low, 0 or 1, but the patient still might deteriorate to become severe pancreatitis. So it might be misleading if you try and risk stratify this patient just based on CT score, just on like initial 0 to 48 hours. So it can be misleading. So you should be very careful in using this score in the initial phase. Apache score, again, it has a lot of variables. That's the main parameter. We need to wait for the lab results. And issue with modified Ranson's and Glasgow-Emery score is you cannot do it in the initial 48 hours. You need to wait for 48 hours. Glasgow-Emery score is being more commonly used by the surgeon, but the caveat is we cannot use it, apply it in the initial 48 hours, which is when we need it the most. So I kind of go with the HAP score in the initial phase. If at least one of the parameters is positive, I will keep them on the list for critical care. They have high potential to deteriorate and use the PSAP score as well. Is that clear? Yeah. So this is the Balthazar CT scoring index. Basically, maximum score is 10. So in the scoring system, it may not be asked in the EDIC part 2. Maybe you can get some MCQs or some CBS based sessions. I'm not sure, but better to know this. So this is just based on CT severity and presence of complications basically. And yeah, I already discussed the problems with CT severity index. So let's go on. Yeah, with pancreatitis, especially in the CBS sessions, you might get a lot of radiology. And so I try to incorporate as much radiology and have a discussion on that. So in the top left picture, can you see my cursor moving?
Yes.
Yeah. So normally the pancreas is very thin and you can't appreciate it nicely. If you can see the pancreas properly, I mean, just by on the first vision, it's probably inflamed. And here you can see this is a normal, I mean, the texture of pancreas. You can see some indentations, some lobulated structure, and it is enhancing, right? It is enhancing like this. So that's how pancreas looks. If you concentrate on this area, it is not enhancing. So this worries the presence of a necrosis. Yeah, it could be a collection of necrosis, but it's difficult to differentiate just with the CT. But if it's more homogeneous, it's more likely a peripancreatic collection rather than necrosis. If it has some solid materials inside and a bit heterogenic texture is there, then it's more towards necrosis. And in the right lower ear, you can appreciate the necrosis nicely. And almost more than 50% of this patient's pancreas is basically necrosed. And you can see some wall-like structure around it. So it's probably chronic and it's going into the walled off necrosis state. And this picture, can you guess what is this?
Pseudocyst.
Yeah, exactly. So it looks more homogeneous, like a collection, and it is walled off. So it's probably chronic more than 4 weeks as well, and it's a pseudocyst. And I think in the last class, somebody asked about fat stranding. How does it look? just got a picture. So normal fat looks like this. And kind of fat stranding is, you can see, appreciate it here. It's basically the lesser momentum. If you remember the MBBS classes, like lesser momentum is a mobile structure. Wherever there is some inflammation, it goes and attaches surrounding structures and becomes like a cake-like material. So that's basically what we are seeing. Normal fat, you don't see it like a stranding pattern, but inflamed fat, you see this reticular formation of this fat. Fat is everywhere, but you don't see it obviously on the CT. But if you are seeing it like this, so that's called the fat strand. Any doubt with this? Okay. Let's move on. If you want to have a look again, you can come back to. All right. So this patient, we have diagnosed acute pancreatitis, managed him. So we have given some fluid resuscitation because he continued to have hypotension with some 5 liters of lignous lactate. But the patient remained oliguric, urine output is dropping, blood pressure although improved with some noradrenaline infusion. So the creatinine is worsening, urea is rising, the lactate remains high. So now the abdomen looks more tense, distended. You are worried about intra-abdominal pressure, you measure it and it's 25. So how do you define abdominal compartment syndrome, and which grade of intra-abdominal hypertension is it in this patient?
When the intra-abdominal pressure is more than 20 millimeter of mercury and there is an obvious feature of the organ failure, it's called abdominal compartment syndrome. In this patient, is this more than 25, so it is grade 4 intra-abdominal hypertension.
So it is 25, just 25, not more than 25.
Oh, sorry.
Yeah. Measured at 25, so.
So grade 1 is 12 to 15, 16 to 20 is grade 2, grade 3 is 20 to 25, 25 to 30 is grade 4.
Yeah. So I got a similar question. The pressure was like 20. The question was what grade it is. So I had to be accurate. If I had said one grade higher or below, I would have lost the mark. So
so it is grade 3.
Yeah, they like this question, abdominal hypertension. So be thorough in it. And so how do you manage?
So in this patient, at first, I would decrease the fluid volume and try to keep it more negative balance after achieving the euvolemic state. And if preferred, I would maintain the pressure adequate, add the vasopressor to maintain the main map. If the pressure is adequate, then I can use the diuretics, and if it is not still now, then and as there is an increase in the creatinine, I will choose the continuous renal displacement therapy. And in case of the others, NG and rectal decompression in these cases of the patient, prokinetics can be used. Internal feeding, if it is not corrected, then go for the probiotic. NG feeding should be lower, and if it is still now corrected, then we plan for the stop the NG feeding and go for the parenteral nutrition. And if the patient is on the mechanical ventilation, then try to make the adequate sedation and pain control. And if the patient is mechanical ventilated, then go for, if not corrected, neuromuscular blocking agent. At first of all, patient should be kept in the lying flat. And these are I can do this for this patient.
It's a thorough answer. That's how you get the maximum marks. So be as thorough as possible in your answers. They're just going to give you open-ended questions like this, and you need to try and score as much as point as possible. It's easy to score, so don't miss out on like small factors like adequate sedation or paralysis. So you have answered it in a perfect way. So that's how I would have answered as well. So if you do this, you will get the maximum mark. Yeah, absolutely fine. So I would recommend reading this management algorithm from the Abdominal Compartment Society. So it's quite accurate and up to date. So and it's a quite important exam topic for EDIC. So please go through that. So this patient is probably intubated by the time with so much intra-abdominal pressure. And as you said, he was already started on CRRT. So he has been in the ICU for 10 days now on RRT. You're doing a follow-up scan to see how things are looking for the extra pancreatic necrosis. So the report says more than 50% pancreatic necrosis. Additionally, it notes the filling defect in the splenic vein. The radiology comments on the presence of prominent gastric collateral vessels. The patient has no signs of active bleeding. Hemoglobin is stable so far. So, what do you think is going on?
So can you see the previous slide again?
Yeah.
Splenic vein thrombosis.
Excellent. Excellent. Yeah. So it is splenic vein thrombosis. Have you treated a patient before with splenic vein thrombosis? Anyone? Fine. Yeah, you are absolutely correct. It's a filling defect in the splenic vein. It's a thrombosis. So, what do you think is the reason for this thrombus? So it can be a complication of acute pancreatitis.
Endothelial
Yes,
injury, which
okay.
occurs because of pancreatitis and inflammation, leads to the thrombosis and back pressure that will lead to the collaterals being distended. And it's a complication of pancreatitis, basically.
Yeah, basically the virtuous triad, right? So inflammation of the pancreas with surrounding structure getting inflamed as well, endothelial injury, stasis, and hypercoagulability associated with inflammatory state. So that's the reason for thrombosis. And you touched upon the complications of like downstream effects of splenic vein thrombosis. Can you explain more on that? So what happens as a complication of this thrombus?
Variceal bleed can happen because of this dilatation of the vessels, and the thrombus can extend into portal or the superior mesenteric vein.
Yeah. So we know of the portal hypertension associated with chronic liver disease, kind of similar effect, but just as a splenic vein thrombus. So part of the gastric vessels get dilated. It's like a segmental portal hypertension, and there is increased risk of GI bleeding associated with this. So that's the importance of this. So how do you treat it?
Anticoagulation.
Do everyone agree with anticoagulating this patient?
Or sir, embolize, get an intervention radiology call and embolize. Maybe
Intervention
remove.
radiology, IR.
Tommy, you mean? Yeah, I don't think anyone is doing that currently, but yeah, interesting. Yeah. What do you think, other people? Do you think you will anticoagulate this patient? So there is no clear consensus on this, whether we should anticoagulate splenic vein thrombosis or not. Again, it's only a consensus statement. There is no evidence. And even there is no consensus whether to anticoagulate this patient or not. For portal vein thrombosis, yes, there is clear consensus. At least more than 80% of the experts think we should anticoagulate. But splenic vein thrombosis, it's an equal split, only like 40 to 50% think about coagulation. And yeah, we need to decide on a patient to patient basis, basically, based on the side effects. Like if they are having worsening gastric varices, probably I would anticoagulate, but if they are asymptomatic, rather avoid it. But this is what the exam expects. To know the controversy around this, they don't want you to give a definite answer. What do you think about the controversy? What is the recommendation available currently? If you say that, if you understand that, that's fair enough. That's what they want to know as well. Fine. Yeah, even if we anticoagulate, there is no evidence to suggest that there is reversal of the downstream effects. So it may not be beneficial in all the patients. But yes, this patient did get anticoagulated. So 2 days after this, he is on therapeutic anticoagulation with maybe say heparin infusion because of AKI. So the patient suddenly develops profound hypotension. Hemoglobin drops significantly, and massive transfusion protocol is activated. You do a repeat urgent CT angio. Angiogram shows a contrast blush from the branch of splenic artery within the peripancreatic collection. So what is the diagnosis? Where do you think the patient is bleeding from? What has led to this complication?
Hemorrhagic transformation.
Of
Gastroduodenal or splenic artery due to due to pancreas itself is enzymatic, or due to the cirrhosis, due to the necrotic or pancreatic enzyme itself erosion.
You're saying it right, just the word you are missing. It has a name. Like we know it's
Pancreatic
bleeding,
cirrhosis.
and we know it's because of the enzymatic degradation. And what do we call it?
What is the sign?
Now, so if you see the CT, I've just pointed it out. It's like a spotter for this may be a CBS exam question, who knows? So that is the splenic artery.
Pseudoaneurysm, sir.
Exactly. That's the word I was looking for. So you can see as a small outpouching, right? So it's a defect in the splenic artery wall, which is locally contained. That is what is called a pseudoaneurysm. But it has potential to rupture and cause hemorrhage. So this is a known complication of acute severe pancreatitis. So that's where it probably bled from. If you didn't have a CT, what are the other source possibilities in this patient for hemorrhage? Where else he could be bleeding from?
Gastric varices.
Yeah. So as we discussed, because of a splenic vein thrombosis, he was at risk of gastric variceal bleeding, and fortunately for him, it was a splenic artery which could be embolized easily. Okay, gave you the answer. So how do you treat it? So this patient was on anticoagulation, suddenly started bleeding. You've done the CT. How do you manage him? You're already transfusing him.
Angioembolization of the splenic artery.
Yeah, that is the right answer. But before that, would you like to do something else?
We would like to give him, as he's going for splenic artery thrombolysis, vaccination.
Reversal of anticoagulation.
Yes. First, you stop the anticoagulation. You would have done it anyway, but you need to say this in the exam, right? These are the points which we miss in the exam and miss out on a mark. Yeah, so you stop the anticoagulation and you reverse it. How do you reverse heparin?
Protamine sulfate.
Yeah, so you can use protamine to reverse it, and you carry on with the massive transfusion protocol. And as you discussed, IR guided embolization is the first option available here. Fine. So his pseudoaneurysm was successfully embolized. However, he remains critically ill, ventilated on CRT. So we are on day 20 now. Now he starts developing fever, new increase in WBC count, and you are doing another CT. So you found this. What is going on?
Infected necrosis.
Yeah. Why do you say it's infected?
Because there is ER within the pancreatic necrotic tissue, black.
Yeah. So as you said it, you're correct. It has gotten infected. How do you want to manage this? And what is the step-up approach?
So at first we go for the antibiotic which can penetrate. At first the patient should be resuscitated following the ABCDE and go for the broad spectrum antibiotic which can penetrate the pancreatic tissue. Most likely it is the carbapenem, and imipenem is the best choice. Also, you can go choice for metronidazole, and somehow tazopane and piperacillin also show some benefit but less. And then we go for the surgical intervention. Here it is preferred for the patient is minimally invasive procedure like endoscopic drainage or minimally invasive procedure for the pancreatic necrotic tissue drainage, and go for and send for the culture sensitivity. And after the report, narrow down the antibiotic of the patient.
Yeah, fair enough. What is the next step? Yeah, next step is obviously the surgical techniques. So nowadays we have some exciting like options available within the endoscopic methods. So he explained it beautifully. Like first step is broad spectrum antibiotics, conservative management, and first choice is carbapenems. And based on sensitivity, we can titrate our antibiotics. Then step 2, percutaneous approaches. Interventional radiology is coming up big in a big way in the critical care therapy. So we try with that. And if that's not working or not possible, then we go for minimally invasive approaches like endoscopic approaches. And the recent improvement in that is the LAMPS stent, lumen opposing metal stent. I've seen a couple of patients having this in my hospital. So I will come to that later. And video-assisted retroperitoneal debridement or endoscopic or laparoscopic approach. And we are leaving the open surgical necrosectomy as the last resort because these patients always end up dying with some complication and have a horrible quality of life in the end with fistulas and stuff. So this is the recommended approach for managing this even necrotizing pancreatitis, acute necrotizing pancreatitis. So this is the LAMPS device. So basically they put in a stent, like a ASD device closure kind of a stent, but it has a hole in the middle. So it kind of creates a lumen between the pancreatic pseudocyst or necrotic tissue and the stomach. So it drains into the stomach basically. And it also gives an access point. So whenever they want, they can go and do a necrosectomy. Come on, they have to do it multiple times usually. So they leave the stent in and till all the necrosis tissues are healed, they leave it in. So this is a picture of it in the CT. This may be asked in questions or anything. You can see the necrotic tissue coming and draining into the stomach. So what happened to our patient? After a 8-week ICU stay, the patient survives. Well done. So he's weaned off CRRT. His renal function has come to a new baseline of creatinine 1.5. So he's about to be transferred to the ward. Now, so what are the long-term sequelae or complications you need to screening for or you need to worry about?
Chronic kidney disease in this patient because he developed AKI. post-intensive care syndrome. The patient can also have chronic pancreatitis and
And the diabetes.
So patient can differ from the glucose intolerance and other pancreas as the pancreas tissue is damaged. So enzymatic problem like I totally forgot lipase, fat metabolism, diet like
Yeah, you have it. Yeah.
uh,
You're all experts in pancreatitis management. So yeah, we can classify or structure our answers like this. So endocrine, part of pancreas, so we need to replace the insulin, and exocrine part, so none of the enzymes are going to be produced, so we need to supplement the enzymes. So basically, enzyme replacement therapy, they need to take some pills which are like combines of combination of amylase, lipase, which the pancreas usually produces, and they take them along with the food as a pill, and it goes into your gut and replaces the enzyme basically. And other local complications like chronic pancreatitis, recurrent cirrhosis formation, and do you know about the disconnected duct syndrome? It's an interesting syndrome. Anyone know about disconnected duct syndrome? It has a clinical implication, right? Especially in necrotizing pancreatitis if the patient survives. Okay, let me give you the answer. So what happens is, because of the necrosis, say there was a necrosis here, so this part of the duct gets disconnected from the main pancreas. So basically this is an obstruction, and this part of pancreas is still active. So the patient can keep getting like recurrent pancreatitis because of this, or it may lead to recurrent fluid collections and a fistula in these patients. So why this is important is, these patients definitely need to have a surgery and get this part removed, because they have attempted stenting this part, and the endoscopic procedures does not work and caused more morbidity and mortality. So the current recommended treatment for this disconnected duct syndrome is distal pancreatectomy. Yeah. Fine.
so can you repeat again? Cannot understand.
Yeah, because of the necrosis, part of the pancreas get disconnected from the rest of the pancreas. So suppose we say there was a big necrosis here, so all the tissue here is destroyed. So the distal pancreas, which has recovered, now is functional, and there is no way for the pancreatic enzyme to come into the duodenum. It is cut off from the rest of the pancreas. So that's what we call disconnected pancreatic duct syndrome. So these patients need to have this active part, which is normal pancreas, but there is no way for the pancreatic enzyme to get drained. Need to get this part removed, like a distal pancreatectomy done surgically, because they have attempted stenting, like endoscopically retrograde, and tried reconnecting the normal pancreas to the duodenum, but it hasn't worked. For long term, best management mode is distal pancreatectomy for these patients. So that's why we need to know about this syndrome. Is that clear now?
Yes, thank you, sir.
Okay. So patient is ready for discharge. So what we need to know about the discharge planning stuff. How would you discharge this patient? So we know the chronic consequences. This might come up in an exam, especially they are interested in, like somebody beautifully mentioned, like post ICU syndrome. Definitely, yeah, totally agree with that. Nowadays, post critical care clinic follow-up clinics are coming up in a big way, so it's definitely needed. So what else you will worry about in the discharge planning? We already discussed that, just need to put it out in. Oh, yeah, fast one. I'll give you the answer. Just For medications, as we have discussed, ongoing analgesia, pancreatic enzyme replacement therapy, we need to organize a specialist follow-up for them. They need to have multiple specialists now. The patient is CKD, nephrology, diabetic, endocrinology, gastro, and general surgery follow-up as well, in case they end up getting duct syndrome, disconnected duct syndrome, and dietitian input for his ongoing management for CKD and pancreatitis. Addiction, he was an alcoholic, remember, so we need to involve the social network for his addiction management and give a proper summary to the primary care physician, which is quite an important thing in developed countries. So, yeah. So these are the structure we are not used to answering generally, but it might end up coming in the exam. So just to put it there as this question. Yeah, that's it I have for you. Any questions? You learned something from this session?
Sir, can you please show the CT images once again?
Yeah. The previous one?
Yeah, sir. Yeah, sir. Okay, sir. Can you show the last CT image with necrosis?
Oh, on this view. Yeah, this bit is the necrosis.
Okay, sir. Okay.
Even here it's necrosis, but it's less than 50%, you can say. Here it's more than 50%. So this Balthazar CT score will be at the maximum.
Yeah, yes.
Any
Sir,
other?
can you please go forward? The last CT cut you showed.
This one?
This one, sir. This one.
Yeah.
It's infected necrosis, right, sir?
Yeah. So these are the gas within the necrosis.
Okay.
So it doesn't happen in all the infected necrosis. It happens around only in 40% of cases, I think. Yeah, but if it is there, it's definitely infected. If it's not there, it could be infected. So it doesn't rule out absence of gas, doesn't rule out infected necrosis. You have to correlate clinically, or MRI is better for differentiating necrosis, which is infected or not, rather than CT.
Okay. Thank you, sir.
And previously, I think the recommendation was to do a percutaneous drainage, FNAC, to get a sample from this and do culture and sensitivity. Now it's not recommended because it increases the chances of fistula formation, intracutaneous fistula, so it's avoided. Happy? Any other doubts? Fatma, I think we're done here. I think we can end the session. Thanks everyone for coming on this weekend.
Thank you, sir.
Thank you very much, Dr. Arun.
Thank you, John.
Thank you, sir. Thank you, sir.
Thank you. Bye. Have a good weekend.